Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with a specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
Welcome back to the GIGU Oncology Boot Camps powered by PCE. My name is Terran Sims, and I'm a nurse practitioner in the Department of Urology at the University of Virginia in Charlottesville, and my focus is urologic cancer. Today, we're going to talk about a new array of choices in prostate cancer. What's best for your patients? We have 2 faculty for the 2 presentations. We will start today with Dr. Rana McKay, and Dr. Balar will join us for the case study. And the second, Dr. McKay is our associate professor for the Department of Medicine, Division of Hematology, Oncology, and Urology at the University of California, San Diego in San Diego, California. And I want to remind you of our learning objectives for this session. We want you to summarize available and emerging agents across the continuum of prostate cancer, apply efficacy and safety evidence, molecular testing, and guideline recommendations to develop treatment plans for patients with prostate cancer, and implement strategies to identify and manage AEs associated with treatment of prostate cancer. So I'm going to turn it over now to Dr. McKay to talk to us about prostate cancer.
Wonderful. Thank you so much, Terran, and it's great to be here today. So prostate cancer is a very common cancer amongst men in the United States. It's the most common cancer that's diagnosed, and it's the second leading cause of cancer death in patients. Incidence rates most recently have stabilized, and mortality rates had been on a decline, which is really due to screening efforts and improvements in treatments for patients. The 10-year overall survival, today is 98%, and that's when we take all comers. But there are patients that have higher risk disease or patients that present with de novo disease that warrant special attention. So risk factors for developing prostate cancer include age, family history, African ancestry, and also a genetic predisposition. So here is the treatment landscape of advancements of treatments for patients with advanced prostate cancer. And really, it was in 2004 that we entered into therapies that actually prolonged life for patients who had metastatic castration-resistant disease with the introduction of docetaxel in the clinic. And then we've seen a series of agents that have been approved with various mechanisms of action, including chemotherapies, including hormonal agents such as abiraterone, enzalutamide, apalutamide, darolutamide. We've seen radiopharmaceuticals enter into the landscape, with radium-223 being the first radiopharmaceutical to improve overall survival for any malignancy. And more recently, we're seeing the earlier use of these agents, both docetaxel, apalutamide, enzalutamide, and abiraterone. New diagnostics that have entered into the clinic with gallium-68 PSMA and F18 PyL PET. So it's really been an exciting time to care for patients with prostate cancer. Typically, patients present with localized disease. They receive definitive therapy, whether that be surgery, radiation, or the combination. The majority of those patients are typically cured of their disease, but there are some patients who develop a recurrence in the form of a rising PSA, termed biochemically recurrent disease. And then a subset of those patients may go on to develop metastatic castration-sensitive prostate cancer, or a subset that's ever so shrinking in number may develop progressive PSA rise despite castration therapy without metastases, and that's termed non-metastatic CRPC. And then end-stage prostate cancer is really characterized by metastatic CRPC, which is inevitably a lethal condition for the majority of patients that have this disease state. So next we'll go into chemohormonal agents for metastatic hormone-sensitive prostate cancer. Really starting in 2015, the way that we treat metastatic hormone-sensitive prostate cancer changed. Prior to this time, we were really utilizing single-agent androgen deprivation therapy with either an LHRH agonist or antagonist as the predominant treatment. Data demonstrating improvement in overall survival with ADT plus docetaxel with a median OS of 57.6 months over ADT alone. And then data from the large Stampede trial, which has really included a very heterogeneous patient population, from patients who had localized disease all the way to patients who had metastatic disease. And even in that context, chemotherapy did improve overall survival compared to ADT alone. There's been a lot of discussion around high volume and low volume disease, and it really seems that the patients who seem to derive the most benefit from chemotherapy are those that have high volume disease. This was a pre-specified analysis that was conducted in the CHARTED trial for patients who had high volume, which was defined as patients with visceral metastases and or for more bone metastases with at least one of these metastases outside of the vertebral column or pelvis. Median OS is 51.2 months compared to 34.4 months, which was statistically significant. The benefit in the low volume patients, I think, seems to be not as predominant as in the high volume patients. So I think there's still some controversy, at least from CHARTED, about the role of chemotherapy for people that have low volume disease. With regards to the Stampede trial, there was also a breakdown by high and low volume disease. In this context, the docetaxel for high volume disease, there's a clear benefit. The hazard ratio here is 0.81. And then for low volume, this is different from CHARTED. There did still appear to be a benefit to docetaxel over control from the Stampede trial. The hazard ratio here is 0.76. So, I think there's some kind of discussion around do low volume patients need docetaxel? So now shifting gears to talk about the role of abiraterone and other androgen receptor targeting agents in the metastatic hormone sensitive setting. We have data from Latitude and Stampede to help support the role of abiraterone in this context. Latitude was a randomized double-blind phase 3 trial of abiraterone plus ADT versus placebo plus ADT in patients with newly diagnosed metastatic hormone-sensitive prostate cancer. And these patients had to have 2 out of 3 high-risk features, which was defined by Gleason score of 8, 9, 10, 3 or more bone metastases, or the presence of measurable visceral metastases. And there was a statistically significant improvement in overall survival in patients with a therapy escalation with abiraterone at a median of 53.3 months compared to 36.5 months. And when we look at the Stampede study from Arm G, we do see a statistically significant improvement with abiraterone compared to ADT alone. Again, keeping in mind Stampede was a little bit different patient population. It wasn't just de novo metastatic. It included a wide spectrum of patients. Similarly, we see the same benefit with AR inhibitors, the second generation AR inhibitors, such as apalutamide and enzalutamide. The Titan trial looked at the role of apalutamide compared to ADT alone for patients with metastatic hormone-sensitive prostate cancer, showing a statistically significant improvement in overall survival with the addition of apalutamide. Similarly, the Enzamet trial also demonstrated an improvement in overall survival with the addition of enzalutamide. The data from the ARASENS trial was just recently released. This trial looked at darolutamide plus docetaxel plus ADT compared to docetaxel plus ADT alone, demonstrating a OS benefit. So more to come on that. The PEACE trial, we have to highlight this. This data were presented at ESMO this past fall. This was a trial that looked at the combination of abiraterone ADT plus docetaxel versus ADT plus docetaxel for patients who had de novo metastatic hormone-sensitive prostate cancer. And this trial was really one of the first studies to demonstrate that actually triple therapy with abiraterone, docetaxel, ADT improves overall survival for this very high-risk patient population that presents with de novo metastatic disease. So when we're faced with a patient in clinic, we have to decide, well, what do we give them? Do we give them abiraterone? Do we give them chemotherapy? Do we give them an AR inhibitor? And these are all the things that we take into account, age, comorbidities, thinking about what are the goals of therapy. There are social determinants as well, time commitment, oral versus IV, insurance coverage, cost reimbursement. There's also disease characteristics, again, thinking about de novo disease, high volume, low volume. Do they have visceral mets? Do they don't have visceral mets? And then patient characteristics regarding performance status and symptoms. And these, can really be helpful in deciding what's the best agent for any given patient. So I will highlight here the role of prostate radiotherapy for patients with metastatic prostate cancer who have not received prior prostate-directed therapy. There were two studies that looked at this, actually the HARAD trial and the STAMPEDE trial. Here is the data from the STAMPEDE trial. And you can see that for the patients who had a low metastatic burden, that use of local radiotherapy to the prostate actually resulted in improved overall survival with a hazard ratio here of 0.68, which was statistically significant. The median overall survival here is 49.1 months compared to 45.4 months in the control. So I think the role of local therapy is evolving even in the context of metastatic disease. And now let's kind of talk a little bit about guidelines, recommendations for metastatic castration-sensitive prostate cancer. So I like to think of ADT plus. I think ADT alone is really no longer a standard of care option, though a lot of patients, I think in real world practice, do get ADT alone. But I think that the thinking here is ADT plus X, and that X could be docetaxel, particularly for those patients with high volume disease, abiraterone, apalutamide, or enzalutamide. And here is really that take home message of patients with metastatic castration-sensitive prostate cancer. It is now standard of care to intensify therapy with either docetaxel, abiraterone, apalutamide, or enzalutamide in addition to ADT, unless there is a strong contraindication to do otherwise. And I think the field is probably going to be moving to triple therapy for those select patients who are even higher risk. So shifting gears, we're going to go into a discussion about castration-resistant prostate cancer. And this is by definition patients who have disease progression despite castrate levels of testosterone, whether they be achieved through medical castration or surgical castration. And these patients do represent a heterogeneous group of patients. Some patients can be very symptomatic related to their disease, or some can be without symptoms. And additionally, some can be with metastases or without metastases, though I think the portion of patients that present without metastases in the era of next generation imaging is actually decreasing. This affects about 10 to 20% of patients within 5 years of a prostate cancer diagnosis. And before recent therapeutic advances, greater than 50% of patients would have died within 3 years. Patients who have castration-resistant prostate cancer, multiple studies have demonstrated that there's a decline in health-related quality of life. And I will highlight here for that population of patients that is NM-CRPC, non-metastatic CRPC, we know that metastasis-free survival is a new and reasonable endpoint for patients that are in this category. So a little bit about non-metastatic CRPC. So this is CRPC with no clinical or radiologic evidence of metastases. We've alluded to this already with new imaging techniques such as, Axumin scans, PSMA PET scans. We are now detecting metastases earlier at lower levels of PSA. And I think this group of patients is ever dwindling. It is recommended that patients who have non-metastatic CRPC, that they undergo PSA testing every 4 to 6 months. And treatment is typically recommended when a PSA doubling time is less than or equal to 10 months, because there's been data to demonstrate that when the doubling time gets to be that fast, there's a high likelihood of metastasis development. And there are certainly tools that are out there to help with calculating PSA doubling time. So now we're going to go into the clinical trials in the non-metastatic castration-resistant prostate cancer setting. And there are a series of trials that are worthwhile highlighting. The Spartan trial, which looked at apalutamide, the Prosper trial, which looked at enzalutamide, and the Aramis trial, which looked at darolutamide. And these trials were all designed in a very similar fashion. They enrolled patients who had metastatic or non-metastatic castration-resistant prostate cancer. Patients were randomized 2-to-1 to treatment versus placebo. And the primary endpoint was metastasis-free survival. There was stratification based on PSA doubling time, based on use of osteoclast-targeted therapy, and based on the presence of local regional disease. Then what's highlighted here is really a little bit of information about the eligibility criteria for the trials and a little bit around the design of the trials, because while they had a similar design, there were some differences in the eligibility criteria. For example, in the Aramis trial, patients with a history of prior seizures or predisposing conditions were allowed. When we look at pelvic lymph node involvement and whether pelvic lymph nodes were considered a progressive event, that really differed across the trials. In Spartan and in Aramis, pelvic lymph node progression was not considered an MFS event, whereas it was in the PROSPER study. Additionally, we see about similar usages of the bone targeting agents. That's important because there's been data to suggest that bone targeting agents, particularly denosumab, can delay the time to metastasis-free survival or can prolong metastasis-free survival. So this is the top line data for these studies, metastasis-free survival and overall survival. And all three of these studies were positive. They met their primary endpoint of improved MFS. They also met a key secondary endpoint of improved overall survival. And these are all appropriate options to consider for somebody with non-metastatic hormone-sensitive or castration-resistant prostate cancer who has a rapid PSA doubling time. I do think it's important to point out some of the adverse events of interest from Spartan, PROSPER, and ARAMES, serious AEs across the studies. 36% with apalutamide, 40% with enzalutamide, 26% with darolutamide. When we look at AEs that are leading to treatment discontinuation, 15% with apalutamide, 17% with enzalutamide. And actually, when we look at the ARAMES trial, the AEs that were leading to treatment discontinuation were almost identical to that of placebo. So just thinking about tolerance for these agents, definitely darolutamide seems to be a very well-tolerated agent. And then when we look at all grade AEs of interest outside of fatigue for patients who had received darolutamide, all of the darolutamide AEs were pretty comparable to placebo. Again, the fatigue was 13.2% compared to 8.3% from ARAMES. But then when we look across Spartan and PROSPER, it is certainly higher with the other agents. So 33% with apalutamide compared to 21%, 46% with enzalutamide compared to 22%. Also raising attention around the rash, which is common with apalutamide, 26% of patients. Falls, 22% with apalutamide, 18% with enzalutamide, but only 5.2% with darolutamide. The fracture rate we think is related to actually the falls, and patients are falling more than they're getting fractures. So, with apalutamide and enzalutamide, we see a little bit more falls and a little bit more fractures. We don't really see that with darolutamide. So I think it's important to sort of understand, especially in the context of these drugs having similar efficacy with the differential AE profile. Hypertension seems to be more common with apalutamide and enzalutamide, but seems to be on par with placebo with darolutamide. So really the take-home message here is to really discuss the potential adverse events that are associated with each individual therapies with your patients before selecting a treatment option in the clinic. Just a little bit of overview of the guideline recommendation for non-metastatic CRPC. We continue androgen deprivation therapy to maintain castration serum levels of testosterone less than 50, but we really need to pay attention to the PSA doubling time. For those patients that have a shorter PSA doubling time of less than or equal to 10 months, there's category 1 evidence to support the use of apalutamide, darolutamide, or enzalutamide in this context. And keeping in mind that the FDA label, it's not restricted to the PSA doubling time, but only patients with a PSA doubling time of less than or equal to 10 months were enrolled on the trials. For patients that have a PSA doubling time of greater than 10 months, observation can certainly be employed, or other secondary hormonal agents. First generation anti-androgens would be in that category. And I think the take-home message here is really to consider early use of approved agents for non-metastatic CRPC to improve metastasis-free survival, overall survival, and quality of life. All right, so now we just chatted about non-metastatic CRPC. Now we're going to shift gears, talk about metastatic prostate cancer. 72% increase from 2004 to 2013 in the incidence of metastatic prostate cancer. The trend started before the U.S. Preventative Services Task Force recommendations for reduced routine early screening. The 5-year overall survival rate is 30% versus nearly 100% for non-metastatic disease. 90% of patients have bone metastases, and really the treatment is evolving for metastatic prostate cancer. There's many new agents with differing mechanisms of action that have now been approved and demonstrated to improve survival for patients with metastatic prostate cancer. So a little word about genetic testing in prostate cancer. We have really learned a lot about the genetic makeup of men with advanced prostate cancer, learning that actually about 30%, if not more, of patients harbor somatic mutations in the DNA repair pathway 19% with localized disease, 23% with metastatic CRPC. Those are mutations that are actually found in the tumor itself. About 12% of men with metastatic prostate cancer actually have germline DNA repair mutations, irrespective of family history. And so that's almost 1 in 10 patients with advanced disease were born with some sort of hereditary predisposition in the form of a genetic cancer syndrome to predispose them to prostate cancer. I think the 2 genes that are the ones that we think of the most are BRCA1, 2, but there are other DNA damage repair gene alterations that can increase a person's risk for developing prostate cancer. So understanding this in this landscape, anybody who has a diagnosis of metastatic prostate cancer should undergo genetic testing. That genetic testing should include both profiling of the tumor, meaning somatic tumor testing, and also germline. So that is now entered into the guidelines and is recommended. So the role of genetic and molecular biomarker testing, as I stated here, for germline genetic testing, it's clinically indicated for basically anybody who's metastatic, anybody who's regional, meaning pelvic lymph nodes, anybody who's very high risk or high risk localized. So even if they're at least an 8, 9, 10 with localized, prostate cancer or PSA greater than like 30 and it's localized, like that would be an indication to do germline testing. There is also indications for testing based on a patient's family history. This is detailed out in the NCCN guidelines regarding the extent of the family history in which you would consider testing a personal history of breast cancer. Germline testing may be considered for patients with intermediate risk disease that also have introductal or cribriform features, as these features have been associated with BRCA1, 2 alterations, or patients that have prostate cancer with a personal history of another cancer. Say they have had a history of colorectal and then developed prostate cancer. For somatic tumor profiling, again, this is the tumor itself, not the patient. It's clinically indicated for all men with metastatic prostate cancer. So really the take home here is recommended germline testing and counseling for patients with metastatic regional or high-risk localized prostate cancer, and recommend somatic tumor testing in all patients with metastatic prostate cancer. So now we're going to dive into some treatments for metastatic castration-resistant prostate cancer. We'll start here with the immunotherapy Sipuleucel T. This is an autologous dendritic cell vaccine. It was actually the first vaccine to be approved for any solid tumor malignancy, and go figure, it was in prostate cancer in 2010. So these are the data from this large randomized phase 3 trial called the IMPACT trial, which looked at Sipuleucel T versus placebo for patients who had non-metastatic castration-resistant prostate cancer that was asymptomatic without visceral metastases, demonstrating a statistically significant improvement in overall survival over placebo, 25.8 months compared to 21.7 months. The hazard ratio here was 0.78 for overall survival. I think something to consider about Sipuleucel T is it does not cause a PSA response, does not cause an objective response, but it's sort of one of those therapies that you just get it in, you get your 3 doses in, and that's sort of it. You never really know if it actually ever works for your patient because of the fact that there's no PSA or objective response. The next data that we'll go into is some of the older data from Cougar 301. This is really the initial study that launched the introduction of abiraterone into the clinic. This was a trial that was conducted for patients who were post-docetaxel with metastatic CRPC, randomizing patients to abiraterone versus placebo. And really, this is a reflection of the limited treatment options that we had at the time that abiraterone was first introduced into the clinic. But it resulted in a statistically significant improvement in overall survival over placebo, with an overall survival of 15.8 months compared to 11.2 months and a hazard ratio of 0.74. The common side effects here were fatigue, anemia, back pain. We know that abiraterone is a CYP17 inhibitor that works by blocking the lyase and hydroxylase activity of CYP17 and can cause a syndrome of mineralocorticoid excess, which means that patients can be at risk of getting hypertension, edema, swelling of the legs, and it can also be associated with LFT abnormalities. So it's something to consider when this agent is being used in the clinic. This was the AFFIRM trial. This was the first trial that launched enzalutamide into the clinic. Enzalutamide is a second generation AR antagonist. So it actually blocks the binding of androgens to the androgen receptor In addition to some of the first generation anti-androgens, it has much higher potency for the androgen receptor, and it also prevents androgen receptor translocation into the nucleus and association of androgen receptor with androgen response elements within the nucleus. So it's got these additional extra properties that the first generations don't have. So it is a good medication. I think one of the key side effects with this medication is fatigue. Affirm, this was a large placebo-controlled phase 3 trial that enrolled almost 1,200 patients, demonstrating the benefit of enzalutamide with regards to overall survival, 18.4 months compared to 13.6 months with placebo, with a hazard ratio of 0.63, and with an RPFS of 8.3 months compared to 2.9 months with placebo. And then moving into the chemo-naive setting. So initially, Abby and Enza were tested post-dose of Taxol, post-chemo with Cougar 301 and Affirm, and then with Cougar 302 and Prevail. These were the two pre-chemotherapy trials that were conducted, and both of these studies demonstrated improvements in overall survival and PFS with earlier use of either abiraterone or enzalutamide. And so as you can see, we're kind of slowly moving these drugs earlier into the clinic. These were actually the first trials to be reported, compared to what we just presented for metastatic hormone-sensitive disease, which are actually kind of some of the later trials as we demonstrated efficacy of these agents in the metastatic CRPC setting. So just to think about side effects of these agents. So with abiraterone, it's dosed 1,000 milligrams daily. It's given typically on an empty stomach. Prednisone is required. And the reason that prednisone is given is to really help prevent significant mineralocorticoid excess, because it sort of stops that feedback loop on the ACTH axis within the adrenal gland. With enzalutamide, it does not require that it be taken on an empty stomach, and there is no prednisone that is given. It is really important to pay attention to drug-drug interactions with abiraterone, and particularly with enzalutamide, there can be a lot of drug-drug interactions. So I think it's important to make sure to get a good history from the patient to understand what they're on and double check, given that these do impact the CYP enzymes. Again, with abiraterone, the mineralocorticoid excess that can cause hypokalemia, hypertension, fatigue, swelling, and there can also be liver toxicity with abiraterone. So there is a requirement to closely monitor LFTs when patients first initiate therapy. There can be, it's not common, but it's something that we watch out for. There can be cardiac toxicity with abiraterone as well, whether it be arrhythmias, AFib, or even cardiomyopathy that can occur. With enzalutamide, the thing to watch out for is that it does cross the blood-brain barrier, it can lower somebody's seizure threshold. So watching for that is really important. Additionally, fatigue is a fairly common side effect with that agent as well. So now shifting gears to the radiopharmaceuticals, radium-223, as I already stated, is the first radiopharmaceutical that was demonstrated to improve overall survival. It is an alpha-emitting isotope that delivers radiation to a 2 to 10 cell radius within the bone marrow microenvironment. These were the results from the ALSYMPCA trial that demonstrated that radium-223 not only improved overall survival, it also helped delay the time to first symptomatic skeletal event and actually did improve quality of life. The most common AEs here were bone pain, anemia, nausea that could take place. Now, I do want to highlight the results of the VISION trial. This trial was just recently reported at ASCO this past summer, and the New England Journal paper is out. It's currently under expedited review by the FDA. So the VISION trial looked at lutetium PSMA, which is a beta-emitting radioisotope that targets PSMA. Patients had to have previously received both at least one androgen receptor pathway inhibitor and 1 to 2 prior taxanes. So these were patients who had received prior chemo, had received prior Abi, Enza, APA, one of those agents, had a good performance status with a life expectancy of greater than 6 months. They were randomized to receive 177 lutetium PSMA plus standard of care versus just protocol permitted standard of care. The trial was positive. It did meet the primary endpoint of overall survival, and currently it's under expedited review by the FDA. So pointing out the median OS in all randomized patients was 15.3 months compared to 11.3 months with a hazard ratio of 0.62. There was a lot of patients who dropped off that were randomized to the control arm. And so they had to assess, re-engage the sites, and did not want to kind of have a underperforming control arm in the context of the study. So even in the RPFS analysis data set, we still see a statistically significant improvement in overall survival, and here the hazard ratio is 0.63.
Thank you. We're going to wrap it up now. This has been a great session on prostate cancer. I want to thank Dr. McKay for your great talk.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.